Good morning, everyone. I want to extend a special welcome to those of you joining us at QI Power Hour for the very first time. My name is Deborah Wright, and I'm with the Health Quality Council here in Saskatchewan. QI Power Hour is a free monthly WebEx offering hosted by Health Quality Council here in Saskatchewan that provides an opportunity for colleagues across healthcare, as well as other industries, to hear from local and national improvement experts on a variety of quality improvement-related topics. Just a reminder that following today's session, a recording of the event will be posted to our HQC website for you to share out with colleagues who were unable to join us in person today. We also invite you to check out our recordings and past presentations on demand, listed at the address on your screen. While you're on our Health Quality Council website, we also invite you to sign up for our distribution list to ensure that you receive regular invites to all of our upcoming QI Power Hour sessions. Over the last number of months, we've been delighted to see how QI Power Hour has continued to spread throughout our province within our provincial healthcare system, as well as to those other organizations in Saskatchewan who have had an interest in quality improvement. We've also begun to see spread of other organizations within Canada and even abroad. Again, welcome everyone to QI Power Hour. Now, we encourage folks to share their questions and insights today during the session by making use of the chat function. You'll find the chat function on the right-hand side of your screen. You can access that chat function by clicking on the message bubble at the top right-hand side of your screen. We encourage you to share your questions, comments, and ideas throughout the presentation. We will have some time dedicated to Q&A at the end of today's presentation. Please send your questions to all participants so we can all join in on the conversation. So let's take a moment to practice this function by typing in the chat the name of the organization you're joining us from today. Great, we're seeing Health Canada. BC Patient Safety Quality Council, Ministry of Health, so great. Everyone's found the chat function, so that's wonderful. All right, and finally, we also invite you to log into your Twitter account and tweet out during the session to share your learnings. You can use the hashtag QI Power Hour and the handle HQCSask. For today's session, we also invite you to use the handle CQIP_SK. All right. So I'm delighted to welcome this morning Shari Furniss, also joined by Drs. Hamilton and Peermohamed. Shari is the Director of Learning and Implementation Services here at Health Quality Council and has led the development and implementation of the first two waves of the Clinical Quality Improvement Program. Dr. Shaqil Peermohamed is an infectious disease specialist and physician lead for the Antimicrobial Stewardship Program in Saskatoon, Saskatchewan. And Dr. Erin Hamilton is a family physician in North Battleford, Saskatchewan. Both are graduates of the first cohort of the Clinical Quality Improvement Program here in Saskatchewan.
Great, thank you, Deb. So I am very excited to be here today and to share a little bit of the program, but mostly to give the floor to our two physicians who have made time today to tell you a little bit about their experiences in the program. So for those of you who are not familiar with the Clinical Quality Improvement Program, I'm just going to take a couple minutes to give you a little bit of background. So this is a sister program to the internationally recognized Mini Advanced Training Program, which is offered at Intermountain Health in Utah. So this program, the Mini ATP, was developed by Dr. Brent James. That's him on the cover of the New York Times Magazine, which is a pretty decent publication. So, you know, it's a program that's actually gotten a lot of notice. And we had sent our physicians to the program for a few years, and they had really great experience and wanted to recreate that here in Saskatchewan. So Intermountain was very welcoming of having us as a sister program. And so just want to acknowledge that their help and support as we created our own Saskatchewan version. So we did want to adopt the program for Saskatchewan. So in June 2016, we had a design session to look at what changes we might want to make it, I guess, a better fit for our Saskatchewan healthcare system. So as mentioned, this was a Saturday in June that we got together for this design session. If you know both how short and beautiful our Saskatchewan summers are, I think you'll appreciate how dedicated the group was to come together for this day. And it was a really nice broad group. So we had graduates from the Intermountain program, both physicians and non-physicians, graduates of other QI programs such as Quick School, CPR School, Lean Leader, our other physician champions, Saskatchewan Medical Association, the Ministry of Health through the Appropriateness of Care work, a representative from our Vice Presidents of Quality group at the time, Health Quality Council, and we had two absolutely fantastic patient advisors who were there for the day as well. So it was an intense day. You can see people really into it, the sun shining in the windows for the day they weren't getting to enjoy. But the group made really good progress. And so where we landed was having a program that would help people be able to do clinical quality improvement work, support clinical QI work in the province, and then start to build this network of teachers and coaches and champions. The group felt that all of these were really essential for building both individual and provincial capability for clinical QI. So these are the program aims, and the course had these 4 key theme areas. So quality improvement in the Saskatchewan healthcare system, so really looking at some of those tools and methods that are specific to how we work in our province. Quality improvement science and methodology, so looking at the scientific method based on Deming. Human side of change, because of course we know that all the tools in the world aren't of much help if you're not engaging people actively in improvement work. And then a deep dive into clinical QI, so some of the change concepts and ideas that are specific to having a focus particularly on appropriateness improvements. Some of the things that make CQIP, I think, a special program, and some of the things we've heard from our folks about what's made it resonate, we have clinician-led faculty, so clinicians are teaching other clinicians. That was a really important thing that came out of the design. Physician coaches, so every participant is paired with a coach, so building, again, that network of coaches. We use the flipped classroom methodology, so participants complete online modules that are more the theory didactic pieces and then come together for very interactive in-person workshops where they can share and learn from each other. Experiential learning, so every participant has a hands-on clinical improvement project to really enrich the learning, and you are going to hear about those projects today, 2 of them. And then networking and community, so really having some time for physicians to get together to share ideas and experiences, which has been a very valuable part of the program, which I'll share a little bit more later. So we did, after the first cohort, had a external program evaluation done. Dr. Lois Berry was the researcher on that. So that's, I think, a little bit of the context. So just kind of getting into it, so as I mentioned, we had this external program evaluation done. And one of the themes that really emerged was the benefit of leading an improvement project and how this has helped people see other opportunities for improvement in their daily work. And you can see some of the quotes that we pulled from the research report of feedback on this QI project piece. So I'd like to open it up now to my 2 physician panelists. And so my first question, and I'll start with Erin, what impact has CQIP had on your work?
Good morning. I had to think quite a bit about this question over the past couple of days since you asked me to participate. So my project actually focused on increasing HIV testing as the first step of having people who are HIV positive enter into the treatment cascade. I had a few ideas when I started about how we could do this, but as I started the program, we did some reading on our first module that focused on the improvement science fundamentals, and we learned a lot about simple versus complex systems. I realized that in just offering the HIV test, that's a simple system, and it's fairly well laid out in guidelines when we should be offering and how we should be offering. But how patients interact with the healthcare system and how we follow up on HIV positive tests, That's a fairly complex system that I don't think that I truly understood as I was going into the project. So the first task was to learn more about the systems. We did a survey of physicians and NPs in our city, and we realized that people don't order tests that they don't intend on following up on. So the first thing we had to do was to establish a really solid follow-up plan for following up any positive tests. We realized that a lot of the contact that young, healthy people have with the healthcare system is episodic. So if we don't offer testing in those situations, then we're missing a lot of testing opportunities. And so these were just some of the things that we realized, or that I realized by doing some reading and having a quality improvement project in mind as I was doing the reading. So looking back, I think that the biggest way that the CQIP program has impacted my work is the idea of systems thinking and seeing problems not just as individual problems, but as part of a bigger system. And I was looking back through some of the notes I took early on in the program, and I found this quote that I really liked. A systems thinker is a perpetually curious person who never thinks they have the whole answer, but is always willing to know what the next step is. If you watch a child, you will see this happen. They are not in the job of solving a problem forever. They're in the job of taking the next step. At the core is constant curiosity about the world that you will never fully understand, but you might take the next step to understand a little bit more. And that was Dr. Don Berwick. And I noticed that that comes up often in my approach to things now since participating in CQIP, is that I'm much more willing to just try something, learn from it, take a first step, know that I don't understand everything, but just to see a problem and be curious about it and try something new. So I think that's the biggest way it's affected my work.
Thank you so much for that, Erin. Part of me feels like I should apologize to people because once you become a systems thinker, you can't undo it, and you will start to see it everywhere, like in line at the grocery store and at airports and all the rest of it. But at the same time, I think it really does change your work and how you approach it. And it's been really exciting to hear your reflections. Shaqil, how about you? How has CQIP impacted the way that you work?
Sure. Good morning, everyone. So antimicrobial stewardship is a big piece of the work that I do with the Saskatchewan Health Authority. And antimicrobial stewardship in of itself is all about quality improvement. So my project was looking at antimicrobial usage in our critical care unit, which is an environment where we can see high rates of broad spectrum usage, and anywhere from 30 to 50% of antibiotics used in critical care units have been shown to be inappropriate. So one of the big lessons that I learned as I was going through the CQIP program was the importance of building relationships and engaging with frontline prescribers, because the evidence is out there about what antibiotics to use in what situations, and there's lots of guidelines that are out there, but trying to translate that knowledge into practice and implement that evidence can be quite challenging. So I think one of the big takeaway messages that I got from the CQIP program was the importance of building those relationships, establishing a team, and leading and implementing change. And through our project over a one-year period, we were actually able to see a 20% decrease in broad-spectrum antimicrobials and anti-pseudomonal antimicrobials as well. And I think subjectively, when we started working with the critical care staff, a lot of the time we would go down to the ICU, and a lot of the suggestions that myself and our stewardship pharmacist were thinking about suggesting had actually already been done. So we saw a lot of engagement with the critical care teams and both the physicians and pharmacists in the ICU that were already starting to think more about their antimicrobial usage for their patients and make some of those changes on their own. So there was lots of empowerment and engagement, which I thought was really cool to see.
Thank you for that, Shaqil. You know, and I really like that focus on relationships because, you know, I think that's really the gap that quality improvement is often trying to address is the difference between, you know, knowing what to do and doing it consistently. And, you know, I think that people side of change is one of the hardest pieces, but it sounds like it was really impactful for your project. So speaking of the projects and the impact on people, so every participant did have this clinical improvement project they were working on, and one of the reasons for this focus on clinical quality improvement was to really identify and foster those projects that had the potential to improve the patient experience. So Shaqil, your project, Antimicrobial Stewardship, what can you tell us about the impact that it's had on patients?
Sure. So as I was thinking about this question, I kind of broke it down into 3 groups of patients, and I'll put patients in quotation marks. So firstly, I think we can think about the patients that we were impacting that were admitted to the critical care unit. And certainly we saw decreased rates of antibiotic usage and decreased inappropriate usage of antimicrobials. But I think on a broader sense, if we look at a second group of people and just look at our population, we can see that inappropriate antimicrobials is a huge driver of antimicrobial resistance. And there's studies that have shown that are predicting that by the year 2050, more people will die from antimicrobial resistance than cancer and diabetes combined. So on a population level, thinking about antimicrobial usage and finding strategies to promote appropriate usage and the right antibiotic for the right patient is absolutely critical. The third group that I kind of thought about that we had an impact with was our healthcare workers. So those frontline clinicians, physicians, and pharmacists and nurse practitioners in the critical care unit and abroad that are prescribing these agents and finding ways to engage and empower them to use the right antibiotic. So to take things one step further, we received funding through the College of Medicine to launch a mobile app called Spectrum, which is free for anyone to download, but it has all of the information on all of the antimicrobials in our local formulary, as well as dosing information, as well as localized clinical guidelines and pathways for various clinical syndromes that take into consideration our local resistance patterns to help promote the right antibiotic based upon Saskatoon's resistance profiles. So we're hoping with this new kind of quality improvement project, we can take things at a whole new level.
That's fantastic. I know as Jocelyn just said, who doesn't love a good app? And I think if you can combine technology to support people in doing the right things, that can be really powerful. And I really love that reflection of, there's the patient that was right in front of you, but really antimicrobial stewardship is something that impacts all of us, whether it's, an antibiotic that we're going to need at some point or a family member. So a lot of ripple effects with that one. Erin, how about you? What's different for your patients now?
What we're hoping is that patients don't have to go and seek out an HIV test, that they're just offered a test when they interact with the healthcare system. So we'd almost want it to be invisible to patients. It's just something that's offered to them, and they don't really have to seek it out. The impact that I can see from this project was that I know of, 2 patients were screened through a walk-in clinic interactions. They were there for completely unrelated reasons. They were going to be sent for some blood work. The clinician asked, since we're sending you for blood work, can we add on an HIV test? It's recommended for every sexually active patient every year. they said yes, and we've had 2 patients test positive who have now been started on antiretrovirals. So I'm quite excited about that. Those are patients who probably would not have been tested otherwise. And I follow one of them in my clinic, and I haven't ever told him that it was a project to offer testing, but I think maybe in a year or 2, I'll maybe discuss with him the offer of the test and see how he feels about it. And we do have a project that's probably going to be going forward to study a little bit more about acceptability of the offer of the test to patients, so we can learn a little bit more about patients' thoughts on being offered the test in different environments.
That's fantastic, and I'm guessing that ability to detect as soon as possible is really important for just getting people started on the right treatment and down the path of wellness.
Absolutely. The sooner we can detect it, the better, and the less spread.
Yeah, wonderful. So in the program evaluation, we asked people about some of the supports. Of course, quality improvement can sometimes be a bit of a steep learning curve, and so we wanted to make sure that our participants had a lot of things in place to help them through the process and to help their learning and growth. One of the things that came through in the evaluation was things that people appreciated, like the chance to network with colleagues, some other things you'll see on the screen, the data analyst support, coaching, just being part of a learning community, people found really helpful. So I'm curious for our 2 panelists, what did you find helpful for managing some of the challenges with the program? And Erin, I'll start with you.
So I would say one of my biggest challenges was I made some errors in judgment in scoping of my project, and in that we probably took on too many areas. What really helped with that was feedback from the network, from the other participants, from my coach, in helping to manage and how to move forward. I think that the networking and working with other participants allowed me to learn about the concepts being applied in very different projects from mine. It provided a lot of support and motivation. You would just be losing energy to work on your project, and then you would come together for a weekend of learning, and you would come away completely motivated to get back going. Also, making the time is always a challenge. There's always patient demands and different demands on your time. And so the coaches, again, and the project sponsors were really helpful in helping me to figure out how to set aside time and make sure we moved forward.
So I think scoping is the problem as old as time, as far as I'm concerned. It's always, I think, one of the biggest challenges. I'm just curious, where did you start with your project, and then how did you, I guess, resize it to have it be a better fit?
We started by involving people from every point of contact. We tried to target every point of contact of patients with the system. So we had mental health and ER and walk-in clinics and primary care and hospital. And we were still in the mindset of we're going to develop a program and we're going to roll it out. And as I went through the program, I realized, no, we need small tests of change starting in some areas and then, expanding. And so we realized that one of our kind of probably best impact areas would be the walk-in clinic, and then secondly, the ER. So we decided to focus on those.
Excellent. And obviously, that was a good starting point for it, because you were able to find patients that needed the testing and benefited from it. So fantastic. Shaqil, how about you? What were some of the challenges and how did you manage them?
So I think one of the challenges that we faced when thinking about our project in the critical care unit was the importance, and I don't think I realized how important it was to have a patient advocate, and with that, how important it is to establish those partnerships and recognize the point of view of patients as well as a key stakeholder in this project as well. So through the CQIP program, we're actually able to identify a few patients that were supporters of this type of quality improvement project, and also gave us some insight into how we can evolve our process as well. So I think one thing that I just didn't recognize at the beginning of this project was the importance of having a patient advocate and building that relationship and collaborating with patients when developing a quality improvement project.
That's fantastic. So I guess I'm curious, how did you involve the patient and what kind of learnings did you have from them that really helped the project?
So when we met with one of the patients, she was someone who has had multiple admissions in the critical care unit and has several antimicrobial allergies, which also makes it very difficult to ensure that she gets the right antibiotic based upon the syndrome that she presents with. So I think the importance here was that having a stewardship program involved in the critical care unit also ensures that there's some continuity and we might have a different lens and know more about some of these patients than some of the critical care staff because we're used to their stories. The other thing that this patient also emphasized was the importance of letting all of the patients and families know that are in the critical care unit about this process and to understand that we're not here to stop antibiotics, but we're here to make sure that you're on the right antibiotic and getting that message across. So we're looking into some ways to ensure that patients are aware of this process and families are aware as well.
That's fantastic. Thank you. So we are now in the midst of Cohort 2, and they had some big shoes to fill because Cohort 1 was an absolutely fantastic group, but they are also really having some exciting learning. We are gearing up for Cohort 3. We're in the middle of accepting applications for it. So as alumni of the program, I would love to know if you have any advice or words of wisdom for those that are considering applying to Cohort 3. And Shaqil, we'll start with you for this one.
So I had 3 things that I thought were important and things that that I thought would be key as if I were going to do this program again. So firstly, I think it's really important to be open to ideas, and through CQIP, I was able to collaborate and get advice from so many different people, not just my sponsor and my project supervisor, but all of the other people involved in the CQIP program. To get feedback from them was amazing and helped us evolve our project on an ongoing basis as well. The second thing that I reflected on was the importance of being adaptable and flexible. I think that through CQIP and quality improvement, we're looking at thinking about new ways of looking and analyzing data. So rather than creating a research project and looking at p-values, maybe a better way to look at things is to run through different PDSA cycles, learn from different interventions, and continue to evolve your process and your project on an ongoing basis. So I think that's the difference between quality improvement and research, is this kind of new way of looking at data and analyzing data. The final message that piece of advice that I would have is so important to collaborate with others. Through CQIP, I was able to build so many connections through SHIPs to help analyze data, to identify patient advocates, to establish better rapport and relationships with the Department of Critical Care, as well as the Division of Infectious Diseases and the Department of Pharmacy, and then also working with my project supervisor, Dr. Susan Shaw, who works in critical care and is also a huge advocate, obviously, of quality improvement. So that getting that feedback was truly amazing.
Thank you for that. And, you know, I think you've hit on a couple of things that I would say I really thought were strengths of the program. I think one of them is that ability to crowdsource your problems. You know, the smartest person in the room is still not as smart as the whole room together. So we had all these bright minds, and, you know, it was really exciting to see people leverage that. And then the other thing, you know, I think you hit on is the whole data piece and really looking at it from a different perspective. And I'm not a numbers person, but, you know, when you see run charts and control charts, it's fascinating what you can learn from looking at your data in a different way. Erin, how about you?
So I agree with everything Shaqil said. I had thought about the need to pick something meaningful for you and your patients, because you do need to have meaning to it to maintain your motivation throughout the year. And we all approach problems with some solutions in mind, but as you're preparing your application, just don't get too attached to your solutions, because, like you said, you get to crowdsource your problems, and you get to learn from your patients. And a big part of the learning is to learn about the system and design your solutions based on what you learn there. So we're never going to get away from having solutions in mind, but just don't get too attached to your solutions as you're forming your project. And yeah, be prepared to learn, be prepared to change based on what you learn, and one thing I was thinking about is how applicable the project is to both small and large projects. So I would encourage any clinicians who are thinking of applying to not feel like you have to be in any kind of leadership or have leadership aspirations to do this program. I think this is a very helpful program for people who are in leadership or who want to do leadership, but it's also very, very practical and applicable to just, not just, but to your clinical work. And so wherever you are on that spectrum, I think that this program can be really valuable.
Yeah, so of course, being at all the workshops and in the discussions, I had a chance to hear about people's projects throughout. And, you know, I think that choosing something meaningful is really key, because, you know, it is going to be hard at times, but when people would talk about their projects, you could just feel how much heart there was in them, and how sometimes that was maybe the only thing people think keeping you going, when, you know, the solution you thought was so absolutely perfect and would solve all the problems actually made it worse or didn't help. And, you know, the other thing I really saw people embodying was having a real growth mindset, so being willing to be challenged, to be wrong about things, and to be taken in different directions. So I think all really good pieces of advice for participants in future cohorts. I'm just going to pause at this point and open up the floor if we have questions for our panelists, or questions about the program that people would like to pose. Yes, and sorry, I should mention, I'm just sitting here waiting. Put your questions into the chat. We do have some monitoring, so we can read those out. As people are formulating their questions, maybe I'll just start with another one that has been on my mind. What is next for you on your QI journey? So you're done the program now, you're officially alumni. but what's next for you in terms of quality improvement? So Erin, maybe I'll start with you.
Last week I put up a run chart on my whiteboard of my COPD visits and quality approach to COPD in preparation for I'd like to have all of my patients have up-to-date puffer technique review and visits prior to the fall season. So as I was thinking about that, I thought, well, why not do a run chart, and we'll start with 3 different indicators, and we're meeting, you know, just for 15 minutes weekly with my team to try to get that going. So we're going to continue with hopefully the HIV testing in the ER, and hopefully we did a few tests there, but I wouldn't say that it's consistent, so we're going to keep working on improving ways of offering HIV testing, and probably more patient involvement in all areas of our quality improvement for our clinic, because that was another thing that became very clear. Like Shaqil said, it was really striking how much having patients involved in the projects both changes and improves the project. So those are the next couple of things on my to-do list.
That's fantastic, and also a thank you. You stepped up to be a coach for Cohort 2, and so it's definitely people are benefiting from your experience with that. Shaqil, how about you? What's next for your QI journey?
So a few things. We're continuing our process in the ICU and are continuing to evolve that process as well to make sure it's as beneficial to critical care staff and patients as well. We're super excited about the launch of our mobile app, which is free for anyone to download and use, and we'll be continuing to create new clinical guidelines and pathways in Spectrum based upon evidence and also based upon our local resistance patterns. And then I've also been working with an internal medicine resident who has an interest in quality improvement and infectious diseases. And we were looking at patients admitted into hospital with candidemia, or essentially yeast in the blood, which carries a mortality rate of around 30 to 50%. And we looked at all patients admitted with fungemia and actually found anywhere from 16 to 18 hours in delay of administration of their first dose of an antifungal. So we've kind of mapped that entire process out, and we were making some fishbone diagrams the other day to try and identify what can be done to improve management of these patients and ensure earlier administration of antifungals. So we'll be starting to work on that this next year too.
It's really exciting to hear actually both of you just talk about how you're using the tools in different settings. And as a somewhat of a germaphobe, I'm really glad that you're on this and spreading this. That's, I guess, a bit of a pun, spreading this to other areas, because it does seem like just one of those areas where there's a lot of work that can still be spread and scoped, and I appreciate you taking that on. So we had a question come through. Can you please talk more about the CQIP training? How long was it, and how did it differ from Intermountain? So it was a 11-month program, so it started with a bit of pre-work, sort of independent work, and then the first workshops. It's now a 10-month program, so we shortened up that pre-work time a little bit and added in an orientation workshop. So there's 4 two-day workshops and one day workshop in the program. So it's a little bit different from Intermountain. So Intermountain is a bit of a shorter program. So this one is spread out over a longer time just to give people more opportunity to do more with their projects. I have not taken Intermountain, but when we had our design meeting and we were looking at adapting it to Saskatchewan, we did incorporate more of, I would say, the people side of change pieces. So that was a little bit different, and then use some very specific tools that they wouldn't have used in Intermountain. So, for example, the A3 as sort of the project plan, project charter document. That would be one example of how it was different from Intermountain. Any other questions coming through on the chat? So this is one for Shaqil and Erin. What skills have you learned through your CQIP experience that you found to be most valuable in your day-to-day practice? Maybe we'll start with Erin on this one.
I would say having a range of tools to use. So like Shaqil said, we just started a fishbone diagram, or, you know, I was trying to figure out how to do something. So I said, well, let's start a run chart and, you know, start looking at some indicators. So just having a basket of tools to use. And then we did some learning around how to run a meeting and how to effectively use huddles and meeting time. And I find that very valuable in a better effective use of my time with my team. So I think that's probably been the most useful day-to-day.
I've heard too that the 5 whys, you've actually used that with patients as well.
Oh yeah, that comes in handy.
In all kinds of relationships, I find actually the 5 whys is a really good tool for unpacking someone's thinking. So, Shaqil, how about you? What tools or skills do you find yourself using more in your day-to-day?
I would echo kind of the same message that Erin had. I think, you know, a huge piece of the work that we do as physicians is quality improvement. And so I think when we're faced with a problem, I think it's important to take a step back and really reflect in order to identify root causes of that problem, and it's often multifactorial. So I think it's easy to just create a simple solution, but that may not be effective unless you truly reflect upon all of the different causes of an issue and work towards addressing all of those different root causes. So I think that's one of the things that I've really taken away from the CQIP program, and using those tools to really develop effective solutions. And it may be a very multifactorial approach you need to adopt for different issues, and that's okay. And I think it's looking at different things from a different angle.
Yeah, you know, and I think again, it's that whole systems thinking where once you start to develop it, you can't undo it, and you really start to look at things and wonder what else could be going on here. What do I really know about my problem? And it really changes the way that you approach issues. Another question coming through on the chat: are the program grads linked to an HQC SAS staff to continue providing support if they need it? So the short answer is we're always here if people need us and want to reach out. We love to hear from alumni. We've tried to connect folks back into the program so that we can have that ongoing relationship. One of the things that we're looking at that came through in the external program evaluation is a desire to continue connecting. So people found it really helpful to have this community and want to continue that beyond the program. So we're looking at ways that we can build some sort of platform or way to continue connecting people and having opportunities for them to learn from each other. I guess for Shaqil and Erin, are there other ways that you guys have been connecting or receiving support post-program?
I think just by being a coach, it's kept me connected, and I feel pretty comfortable if I need support to just call or email and say, hey, who can help me with this? And staff has always been really helpful about providing support and directing me to where I can get help.
Excellent. Another question that just popped up on the chat. So now that you have caught the continuous improvement bug, how do you inspire others that you work with that maybe aren't quite as on board yet? I feel like we should start with the infectious diseases person on
I think one of the ways that I've motivated some of my colleagues to do some of these kind of quality improvement projects or think about this from a different perspective is to just reflect upon the patients and think about how can we, at the end of the day, we're all here to provide effective and optimal care to our patients. So I think it's always important just to keep that as our motivation and our goal. And I think no matter kind of how much work you have to put into this, and people will always be receptive to trying to make things better for their patients. So I know that with some of my colleagues with the Division of Infectious Diseases, we've started talking about how can we ensure that patients with bloodstream infections that carry high mortality rates are identified, and to ensure that they're on the right antibiotic and get involved in those cases earlier. So we've already started to kind of talk about these things in our division meetings, which is so exciting to see, and develop different strategies for candidemia or for Staphylococcus aureus bacteremia, different things that we know carry mortality rates that are 30 to 50%. So we think about, at the end of the day, we're here to make things better for our patients and keep that as our goal.
That's fantastic. Erin?
I would agree with that wholeheartedly, is that everybody wants to do a good job for their patients, and so if we can always bring it around to how can we improve care for the patients, most people are on board with that right away. And using the 5 whys with colleagues I find helpful, but you just have to find a different way of phrasing it other than just asking why 5 times and sounding like a 5-year-old. But being very curious when people are talking about a problem or an area for improvement, trying to ask, why do you think that's a problem? Why do you think that problem's there? How could we learn more? And being very curious about their thoughts helps to engage people.
I feel like curiosity might actually be the most powerful tool in QI, is that ability to stay curious and to see where that curiosity takes you. Jocelyn, are there any questions on the chat that I've missed?
I don't think so. The last question I think kind of covered the one that I had put through earlier. They're sort of similar, so I think we're good.
So I'm just going to mention, as I said earlier, Cohort 3, we are currently accepting applications for it. The application deadline is June 11th. So there'll be some online work that can get started right away, but the first face-to-face meeting will be in September. So if you are interested, I would encourage people to visit our website. You can download the application guide as well as the application itself. Also, as mentioned, we had an external program evaluation that was completed, so that will be appearing on our website soon. Also, you can follow us on Twitter at CQIP_SK, and we'll be tweeting it out once it's posted. As well, if you're like me, you always think about the exciting question about 10 minutes after the session has ended. So our speakers have very kindly said that they'll be available if you do want to reach out to them, if there's things that you want to chat about that you either didn't think of or would just like some more time to explore, as well as myself. If you have any questions about the program, certainly feel free to reach out. So unless there are any more questions, or Erin, Shaqil, if there's anything else that you wanted to add?
Nothing on my end. No.
Yeah, no, I think I'm good, but thanks for inviting us to share our experiences with you.
Well, thank you so much for making the time, being available, giving your honest replies to the experience, and I know that your comments and wisdom will be very valued for those that are currently in the program and are thinking perhaps of applying. So our great appreciation here at HQC. And with that, I will turn it back over to Deborah James.
Great. Thank you, Shari. And again, just to echo Shari's thanks and appreciation both to Erin and Shaqil for making the time and spending some time with us sharing their experiences. We also hope that you'll join us next month for QI Power Hour. We will be back on June 22nd with a presentation from Matt Gray and Sarah Collins from the Community Safety and Wellbeing Branch with the Integrated Justice Services of the Government of Saskatchewan. They'll be sharing about their experiences to date with hub tables in the province, which help to coordinate and integrate services from across a variety of sectors and service providers to link identified at-risk individuals to the most appropriate services to support them. Professionals from a variety of disciplines discuss specific situations regarding citizens facing elevated risks and then develop immediate, coordinated, and integrated responses through the mobilization of resources. We welcome you to also provide your feedback on today's session by completing the survey that we'll launch as you close out of the WebEx. We appreciate your feedback and look forward to connecting once again next month. Thanks.